All right, good morning. So we're going to go over the neurologic examination today. And the purpose of this is really to kind of answer the question, how do we evaluate all of this anatomy that we've been talking about? And the neurologic examination is how you can get information about all these motor, sensory, visual pathways, and so on. And so we're going to go through the neurologic examination talking about going through it like this. And so in this lecture, we'll be going through mental status, speech and language function, and we'll get just a little bit into cranial nerves 1 and 2. So the first thing I want to emphasize, I'll just say a little bit about the history, but I just have to put a plug in here that I would say almost always, if I get through the history and I don't know what's going on, that's bad news. So it usually is the history. In neurology, we spend a long time getting the details and the story. That is really invaluable. Now, the neurologic examination, as you'll see, is a very elegant, precise, accurate examination. It's amazing how we can figure things out on the exam. But we use the examination really to, kind of solidify what we think is going on from the history. Every once in a while, the examination will kind of open my eyes and say, okay, I didn't really get that from the history. But these two work together really well for figuring things out. And I just want to emphasize that the neuroimaging, although the neuroimaging is incredible, and the technology improvement in that is amazing, but you don't want to just rely on this and just say, well, we've got these incredible brain scans. Let's just get a brain scan. We don't really need to know much about neurology. The brain scan will answer the question. And so I always show this. This was quite a long time ago that a patient came into the emergency room with sudden onset left-sided weakness. And this is a head CT scan. We can always tell a CT because the skull is calcified. Okay? And so we've got obviously something right here. Now when we look at CT and MRI scans, you always have to imagine the patient is lying on their back and their feet are coming out toward you. All right, so this is the left side of the brain. Okay, and so the patient had this CT, was rushed off to surgery, and had this mass removed. Now, is there any problem with that story? It's the wrong side, right? Left-sided weakness, where should the lesion be? It should be on the right side of the brain, right? So here, this is very impressive, obviously. But it turns out this is what's called a meningioma, which is a benign brain tumor. The patient almost certainly had that for decades. Okay, and so the scan was so impressive, but it didn't fit with history. And when we later saw the patient, it didn't fit with the exam either. Okay, so we use the neuroimaging to, obviously very, very helpful. But in this case, we're just totally swayed by the neuroimaging and forgot everything about the neuroanatomy and all of that, and so an inappropriate surgery was done, really. So the patient had a stroke on the right hemisphere, and the thing about head CTs is they don't pick up a stroke very well during the first day, and so oftentimes the CT is normal early on in a stroke. Okay, so that's my little plug here about the history and the examination. So I went over this in my orientation lecture, but we'll be going over this again and again and again in this course, that we first want to localize things. It's the key in neurology. Someone comes in with weakness, which is one of the more common presentations in neurology, and weakness can localize anywhere between the cortex all the way down to the muscle. And so we have to localize the lesion first because that's going to guide what testing we're going to do. It's going to determine everything. And so, again, our goal for the course is really that you're comfortable localizing lesions. Is it cortical, subcortical? Is it in the brainstem or cerebellum? Is it in the spinal cord? We're going to talk about these cells later. Motor neurons in the spinal cord called anterior horn cells. Is the problem with the roots or plexus, peripheral nerves, neuromuscular junction, or muscle? Okay, so that's how we think when we have a neurologic patient. We have to figure out which level of the neuroaxis is involved. So once we've done that, then we begin to think about, okay, what could be the cause, the etiology? Okay, so this is just kind of a big picture of a few things in neurology that come on suddenly. The patient was normal, and then all of a sudden, something catastrophic happened, or they had this very sudden onset problem. that is usually going to be a cerebrovascular issue, stroke, hemorrhage in the brain, something vascular. Things that are slowly progressive are often expanding mass lesions, like that acoustic schwannoma I talked about the other day. That's a benign tumor, but it slowly grows, and so the patient will gradually have hearing loss, ringing in their ears, but it doesn't just come on, out of the blue like that. That's more like a stroke presentation. Things that come and go in neurology, multiple sclerosis would be a classic example of that. I mentioned multiple sclerosis as a subcortical condition that affects the myelinated pathways, and multiple sclerosis comes in attacks. Patient will have an episode, then they'll get better, and then they'll have another episode, and then they'll get better. We could put a lot of things here, even like migraine headaches would be more of an episodic kind of a condition. Then we have relentlessly progressive diffuse lesions, and this would be our whole big category of neurodegenerative diseases, and we'll go through all of those. Alzheimer's would be kind of the classic example. It's something that affects the whole brain, and every 6 months you see the patient back, and they're getting worse as more and more of the brain is affected. Okay, so just a little bit here on the neurologic history. As I mentioned, this is really key in neurology. So it's an accurate chronological, detailed description, and this is usually going to be our most important factor here. So this is I tried to recount this as best as I could, an actual encounter that I had with a patient who came in and told me, I've been feeling dizzy recently. So I asked, well, tell me what happens. And he said, well, I just get dizzy once in a while, that's all. It's hard to explain. One doctor told me it was probably a virus. I saw Dr. X, who ordered a brain scan, and then he sent me into an ear, nose, and throat doctor who did some other studies and thought that, and I let the patient go on for longer than this. Okay, so I'm giving you the abbreviated version. But what do you really want, when you're listening to the history? Yes, you're interested what, other doctors the patient saw and so on, but you really want to get the story. What do you mean by dizzy? You want to find out what is really being described. So the patient is kind of going off on other things. So eventually, I interjected, well, tell me about the first time you noticed the dizziness. Can we put some details on this? Oh, it's been going on for quite a while. I figured it was probably the flu at first. Okay, don't give up. We don't have any information yet, but we need to keep pushing. Well, tell me about the first time. I was at home and I just felt dizzy. I wish I could describe it better. Again, have to be persistent. What were you doing at the time? I was just rolling over in bed. And as we'll see later, that's actually a really helpful clue. So I asked, well, use another word besides dizzy to describe what you felt at that moment, because dizzy is one of those words that can mean about 100 different things. Is it lightheaded? Is it room spinning? Is it I'm falling? Can mean lots of things. So the patient, well, I felt like I was on a boat and the whole room seemed to be moving around. Now that's a description of vertigo. So now we're actually honing down on something that's closer to what the patient actually has. I also felt nauseated and threw up, which most people do when they have vertigo. It was awful. That's about it. Then I went to see my doctor to try and, well, first tell me what happened next at home that day. Well, that seasick feeling lasted about 10 seconds. Now we're getting some details. And I thought I was going to die. Then it was over and I felt okay until it happened later that afternoon. So this is something that was coming and going. Have you noticed that rolling over in bed often brings on those spells? Patient, yeah, and it's funny that you ask, but it seems to often happen when I roll over or turn my head to the right. That will bring it on almost every time. Not that that means anything. And when we learn about this condition, you will know, okay, we just figured out what this patient has. But all the sophisticated tests in the world would not diagnose this condition. Brain scan is normal. You could do every blood test. This is a problem in the inner ear. Very common condition called benign paroxysmal positional vertigo, okay, that we'll come to later. And patients have these episodes of intense vertigo, usually brought on by head movement in a certain position or rolling over in bed. Okay, but that was only diagnosed by the history. And then as we'll see, there is something on exam you can do to positively diagnose these patients. All right, so let's start with the mental status examination. And I'll go over this fairly briefly here. And so obviously you're going to spend more time on this if the patient is coming in with memory loss, or if the family is noticing that, or if you're concerned about that. If you have someone, a 29-year-old coming in with migraines who's just obviously very articulate and so on, then we won't do as much detailed testing here. But orientation questions would be to person, place, time, and situation. All right, so what's your name? Where are you? What's the date? What brought you in today? Those kinds of things. In terms of memory function, we like to test immediate recall, and then recent and remote memory. And in our lecture on memory later on, we'll spend more details on this, but there are a lot of different ways to do this. We can ask a patient to remember objects, so I like to ask a patient to remember 4 objects, and I would strongly suggest you use the same ones every time, or you will forget. If you're using you're just coming up with things on the fly, then you'll get confused yourself. So I ask, remember Boston, Mr. Johnson, red car, and tunnel. See, the patient can repeat them back. If they can't, give them another practice, and then say, okay, good, now I'm going to ask you to remember those in about 5 minutes. Okay, and we'll discuss later the anatomy of what's involved in that. Attention, we can test that by giving the patient numbers, like 7 numbers, and ask to repeat as many as possible. Okay, we do some math testing. Okay, remember the angular gyrus I said is important. If you have a lesion there on the dominant hemisphere, then patients will have difficulty doing that. They'll often come in with some kind of vague confusion, and you do all this testing, and wow, they can't do math at all. Now, it is important when we do this that we kind of get a sense of the patient, how much education do they have, and all of that. That's an important factor when we're trying to consider the significance of some of this. Okay, we test construction. I like to ask the patient to draw a clock with the big hand, little hand at 11:20. You can have the patient draw a cube. We'll see later what anatomy you're testing when you do that. And you will hear neurologists ask kind of strange things at the bedside. So we'll have a patient maybe interpret a proverb or answer how are an apple and a banana alike? Okay, and we think, well, it's easy, a fruit, but it's amazing how often that can be a challenge for patients that have some cognitive issues. I have a neurologist colleague who likes to ask patients, do helicopters eat their young? And most people do kind of what you did, you chuckle a little bit, but someone with Alzheimer's, for example, may, well, and I suppose under certain circumstance they might, so they don't find that as an odd question. Now, general information, later on we'll call this semantic memory. These are just kind of basic facts that, we all know, like who's the president, how many weeks in a year, what is an island, things like that. And there are a bunch of objective tests, and these all become kind of annoying because they get copyrighted and then you can't use them. And so, but one common one is the MoCA test, the Montreal Cognitive Assessment. It doesn't take very long to do. You get a 30-point scale. And so we can go through and ask the patient to do all of these things. We can get a score. And then that's very helpful if you have someone that has, a cognitive issue. You can use that and follow that over time. I will not ask you the details of this test. I just kind of want to give you an example of things that you can do. So they're testing similar things, construction, some naming, memory, and so on. Now, in the hospital setting, we do this quite often in the emergency room where, time is of the essence, especially if we're thinking of stroke and things like that. We need to make some quick decisions. So we'll often just very quickly ask the patient to follow 3-step commands. Okay, so a 3-step command is touch both shoulders 2 times with 2 fingers. Okay, and if someone can do that, you're feeling pretty good about their cognitive status. After they're admitted, you can come back and do more detailed testing. So that would just be a very quick 3-step command. 1-step command, close your eyes. That's the easiest command, a simple midline command. So if someone can't follow the command to do that, that's obviously very concerning. 2-step command, close your eyes and point to the ceiling. Okay, so anyway, neurology residents will appreciate you as a savvy medical student if you're reporting patient can follow 3-step commands, because it's quite meaningful to us. So to have consciousness, we need to have two neural structures intact. The reticular formation, remember I mentioned in the brainstem, all those neurons that are kind of like the light switch to activate the brain, and you need to have one hemisphere intact. What that means is that someone can have a massive stroke on one side of the brain, but if the other side of the brain is intact, the patient will be awake. Okay, so two conditions, probably the two most common that we see that where someone comes in confused would either be dementia, again like Alzheimer's, a classic example of that, or encephalopathy. Neurologists like the term encephalopathy, psychiatrists like the term delirium. They seem to be almost interchangeably used. We'll see there is some difference really in terminology. So it's important. Someone's in the emergency room, you don't have the history. How can you determine whether this is a patient who's demented or if the patient is just encephalopathic? So of course, Alzheimer's, I said, you're going to get a gradual deterioration of the whole brain over time, but if you're just seeing the patient for the first time, it may not be that easy to determine. Encephalopathy or delirium, this is something that comes on acutely due to metabolic disturbance, and there are hundreds of causes of encephalopathy. What do I mean by metabolic disturbance? The patient has an infection, like a pneumonia or a bladder infection, or the patient took their medications in the wrong dose, and it's a medication that causes confusion, or the patient's intoxicated. And these would all be things that could cause encephalopathy. So we need to kind of sort out which we're dealing with. So here's kind of a helpful table. So encephalopathy, if you have the story like the patient was normal 5 hours ago and now they're confused, well, that fits for encephalopathy. We'll see there's a differential here, of course. That doesn't fit with a dementia, right? You don't get a dementia like that. So there the story would be it came on over a long period of time. So it's chronic progressive. Encephalopathy will be a fluctuating course, all right? So every time the patient misuses their medications, they get confused again. Or every time, start drinking alcohol, there's another episode of confusion. So that would be kind of a fluctuating course. But really what's very helpful seeing a patient at a moment in time is the level of attention. Okay, in encephalopathy, these patients are sleepy confused. Okay, and so you come in, they're drowsy, and you have to tap them on the shoulder. All right, Mr. Jones, wake up. And Mr. Jones wakes up, kind of groggily answers a few questions, and then falls asleep again. That's what encephalopathy looks like. Very different than dementia like Alzheimer's. These patients, they may have really great poverty of information from their dementia, but they're wide awake appearing. Okay, superficially, someone, even with an advanced dementia, can appear normal. They're friendly, they're socially interactive, that kind of thing. So the level of attention here is a big distinguishing feature between these two. And of course, encephalopathy, once the drug overdose resolves, once you treat the infection, the patient's back to normal. Okay, whereas as we'll see, there are very few things in the dementia category that are reversible. Okay, any questions about mental status here before we move on to speech and language? Yeah. Yeah, it is a memory test, but as we'll see, something like working memory, one of the best ways to assess that is through attention-type questions. So, yeah, it is a memory test, but that overlaps with attention very much. I think when we have our lecture on memory, and I'll go through all the specific tests that can be done to evaluate different memory components, that'll come together a little bit better. Now, speech and language. First of all, speech is a speech disorder. We don't want to confuse that with the language areas that we talked about last time, Wernicke's, Broca's area, and all of that. So dysarthria, or slurred speech, is a speech disorder. And this can involve lots and lots of things, neurologic and neurologic, non-neurologic. So for example, the patient, let's say, who has a bladder infection and is confused from that. Well, they're often going to have slurred speech. Someone who's intoxicated will have slurred speech. So encephalopathy will frequently have a dysarthria that goes along with it. Okay, or we can have abnormalities, let's say, of the hypoglossal nerve. The tongue isn't moving. Well, that's going to affect your speech, right? So lots of things that can happen in the mouth can also affect the ability to articulate clearly. So that's a dysarthria, slurred speech. Aphasia refers to involvement of these language areas that we mentioned yesterday. So remember, most individuals are going to be language dominant on the left hemisphere. Now, if we have someone who's left-handed, and this is one of the things we do just routinely, when someone comes in with a stroke, we want to know, are you right or left-handed? So it does make a difference. We want to know, are you more or less likely to be language dominant on the right or left hemisphere? And so we can test language function quickly, several ways. Repetition is one of the best things you can do. Because if I ask a patient, can you please say, today is a sunny day? Well, they understood that in Wernicke's area, right? But then to get the words out, that has to go through the arcuate fasciculus to Broca's area, and then they repeat the sentence. So you really test both areas when you have someone repeat a sentence. Now, one thing about neurology is just helpful to know, when we talk about lesions in the brain, they are rarely 100%. All right, so someone may have a middle cerebral artery stroke that's affected part of the language areas, but not all of it. And so usually if we're thinking someone may have a language disorder, they may be able to repeat a simple sentence like that, but when we get to more complex sentences, then they have difficulty. So if I really want to test this further, I'll have a patient say things like, please say, now that he has come, we must go away. It's a little bit harder. And then my most challenging one, again, you don't need to know this, but if someone can repeat this, I'm pretty confident they don't have a language disorder. I'll ask a patient to say, now that cold and icy January is here, motorcyclists must beware. Someone can repeat that, I feel good about their Wernicke's and Broca's area. Okay, so I'll have a patient name objects. Something like knuckles would be good. Maybe to make it harder, not just the watch, but what part of the watch is this? You can point to your eyebrows, any number of things. We can ask a patient to read. That can be very helpful, and ask a patient to write. So on our screening exam, I would say we probably do repetition and naming. If the patient does well there, then we're probably not going to go on and do further testing. All right, so let's say more about these language areas. So first of all, a lesion of the posterior inferior frontal gyrus, remember, can give us this expressive or Broca's aphasia. And so as a big picture, it's helpful to divide aphasias into, are they fluent or non-fluent? That would be a good starting point. And Broca's aphasia is a non-fluent aphasia. They just have a poverty of speech output, very little coming out, very effortful to get any words out. And they lose the normal prosody, the melody that comes with speech. We take for granted the things like being able to breathe and speak together, and how all that can be coordinated so well. And they have great difficulty with all of that. And here is Broca's area, and it's very close to the precentral gyrus. So usually this is caused by middle cerebral artery stroke. And so almost always when someone has a Broca's aphasia from an MCA stroke, they're going to have associated weakness on the opposite side of the body. So those two things usually go together. Now, Wernicke's area, I emphasized here that Wernicke's area is on the posterior portion of the superior temporal gyrus. There is a little bit of function here out into the supramarginal and angular gyrus, but this is definitely the most important part of Wernicke's area. All right, so if someone has a lesion of that area of the brain, now they're going to have a fluent aphasia if it's just isolated to Wernicke's area, because Broca's area is intact. They can speak, they can get words out, they can go on and on, okay, but now they don't understand what you're saying. And so these are just very fascinating conversations. You say something to the patient, and their response has very little to do with what you just said. And so you just kind of have this very, two parallel conversations going on. The patient is usually, they're not aware of this, And so they're often a little frustrated with you for not communicating clearly, it can seem like, but they just don't understand. And when you listen to someone with a fluent aphasia, listen carefully to the words that they say, because they always make these paraphasic errors. Paraphasic errors are either a word that doesn't exist or a word that exists, but it's used in the wrong context. And that's a classic feature of Wernicke's aphasia. So the grass is greel. Greel would be a paraphasic error, or the grass is blue. And we name the different subtypes of paraphasic errors that I don't care you know about, but listen for those in someone with a Wernicke's aphasia. I'm going to save the last 6 minutes or so of the lecture to show you a video of a patient that has a Wernicke's aphasia. Now, if someone has a massive middle cerebral artery stroke that affects both Wernicke's and Broca's aphasia, they have what's called a global aphasia. And these are our most devastated stroke patients, really, because they don't understand and they can't talk. Okay. So again, someone with a Broca's aphasia, Wernicke's is intact, so they understand. If you were to ask a patient with a Broca's aphasia, hold up 2 fingers, they can follow commands and so on, because all of that is in Wernicke's area. Someone with the Wernicke's aphasia would do very poorly at following commands. Yes? Yeah, good question. So the question was about writing, typing if you have a Broca's aphasia. Usually, but not always, all forms of ability to communicate like that are affected pretty much in parallel. So if someone with a Broca's aphasia, I have a patient I followed for years at the VA, and all he could say was pee-pee. And you can imagine, patients with Broca's aphasia often have depression. They're very frustrated. They can't communicate. That's all he could say as he tried to get words out. And he had the same difficulty writing anything, any form of, it all seems to be affected in parallel. I've seen a few patients that couldn't speak very well, but did better getting things out by writing or typing. But for the most part, they tend to be all affected to the same degree, fortunately. Now remember the pathway that connects the posterior superior temporal gyrus with Broca's area is the arcuate fasciculus. And so this is not very common, but occasionally we can have a small lesion that just affects the arcuate fasciculus. And so these patients usually come in with kind of a vague difficulty talking. So you do all of your language testing, and what's most helpful to nail this down is that patients with a lesion here have great difficulty repeating sentences. So they may do pretty well just in fluent, speak, normal conversation, little bit of difficulty, but when you ask them to repeat a sentence, which remember, now they need to understand, okay, he wants me to repeat this sentence, but then they can't move the program very well to Broca's area to repeat back what you asked. And so this is called a conduction aphasia, very common board question, I would say, and you need to associate that with a lesion of the arcuate fasciculus. Okay, all of this is supplied by the middle cerebral artery. Okay, so depending on how big or small the stroke is, that will, tell us how significant the aphasia will be. Okay, now there are some other types of aphasia called transcortical, motor, and or sensory aphasia. And this happens when we have what's called a watershed stroke. And so this is often happens, for example, someone has a cardiac arrest, their blood pressure is non-existent for a period of time as they're being revived. And during that very low blood pressure kind of setting, the patient can have strokes in these in-between vascular distributions. These are the watershed areas. There's a little bit less perfusion in these areas of the brain, so they're susceptible to stroke during prolonged low blood pressure episodes. So we have a watershed area between the vascular territory of the anterior cerebral artery and the middle cerebral artery, and we have a watershed area between the vascular territory of the MCA and the PCA. And so these areas are not Wernicke's and Broca's area, but they're around Wernicke's area and around Broca's area. And so patients look a lot like a Broca's aphasia. If it's a lesion up here, they look a lot like a Wernicke's aphasia. if the lesion is back here. But the biggest thing that is preserved in these patients is they can still repeat things pretty well. Because in a watershed stroke, Wernicke's and Broca's are still intact, the connecting pathway is still intact, so they have the circuitry there that's necessary still to repeat sentences. All right, so here's kind of a busy table to help you distinguish between all the different types of aphasia. So let's kind of go through this here. So in a global aphasia, big MCA stroke, Broca's area is affected, so they're not fluent. Wernicke's is affected, so they can't comprehend. We've destroyed everything, including the arcuate fasciculus, so they can't repeat sentences. Okay? So that's a large MCA stroke. In a Broca's aphasia, remember this is a non-fluent aphasia, but Wernicke's is intact, so they can understand. Okay, but that arcuate fasciculus that's wanting to get into Broca's area, since Broca's area is damaged, they can't repeat sentences. So the lesion is inferior frontal gyrus. Okay, so the transcortical motor, again, superficially you would think, this looks like a Broca's aphasia. It's non-fluent. Wernicke's is intact, so they understand. But since Broca's area is actually intact in these patients, it's the area around Broca's that is affected, they do pretty well repeating sentences. Okay, so that's a distinction here with the transcortical motor aphasia. Mesial frontal, just think cortex around Broca's area. All right, so Wernicke's aphasia, are they fluent? Yes, because Broca's area is fine, getting lots of words out, but they can't understand. And since Wernicke's area is affected, they can't generate the pathway forward to Broca's area, and they don't really understand what you're asking them to do anyway when you ask them to repeat a sentence. Transcortical sensory, remember, it looks a lot like a Wernicke's aphasia. They're fluent, but they don't understand. But the hard wiring, Wernicke's, arcuate fasciculus, Broca's, is intact, and so they can repeat sentences. So the good question to ask here is, well, how can someone who can't understand repeat a sentence? And that's a very good question. And what they often do is, in conversation, they will echo back things that you say. Like I might ask a patient, what's your name? And they may repeat, what's your name? And so they didn't really understand that, but yet they kind of echoed a sentence back. And so they would have some, we look for some evidence of preserved repetition. Okay, now if a patient has a really big watershed stroke that's both anterior and posterior, we call that mixed, so it's both sensory and motor. All right, so they look like a Broca's aphasia, they look like a Wernicke's aphasia, but again, the circuitry is intact, so you look for some evidence of ability to repeat sentences. And then remember our lesion of the arcuate fasciculus. They're pretty fluent, they understand, so the main thing is that they can't repeat sentences. Okay, so certainly the ones I want you to know very well are global, Broca's, Wernicke's, and conduction aphasia. Those are our 4 classic aphasia syndromes, and those are the ones that I'll ask you about. Okay, let's do a little bit on cranial nerves, and then we'll stop and show a video. Any other questions actually on language? Yeah. Can they communicate with what? Yeah, it's similar to the question asked earlier. They usually have a lot of difficulty with that. So the different types of language, both for output and reception, they're laid down on different areas. And so you can sometimes have, speech a little more affected than writing or drawing, things like that. They tend to be affected in parallel. The language areas are fascinating. I saw a patient years ago who spoke 3 languages, and he needed to have surgery to remove a focus of his brain near Wernicke's area that was causing seizures, and the seizures couldn't be controlled by, all the seizure medications. And so, well, it's kind of a long story. How do I tell it concisely? But he said only the one language he really didn't want to lose was Spanish, because most of his family was from Mexico. And so we were actually able to, not me, one of my colleagues, during surgery, you can put these little electrodes over the brain. You can deliver a little electrical impulse. The patient's awake. It doesn't hurt. You can touch the brain during surgery. It's not painful. And you can basically inactivate different parts of Wernicke's area, so we could kind of figure out, okay, here is the English part. I think he spoke German. And sure enough, we could, remove the seizure focus, and he lost the ability very much in other language areas, but his Spanish was still excellent. So, that's very subdivided in terms of different function. Okay, so the olfactory nerve, we'll certainly spend the least time on this. The olfactory nerve fibers are actually found here in the nasal olfactory mucosa, okay, in the nasal cavity. And they have to pass through the cribriform plate here into the olfactory bulb, and then here is the olfactory tract. So that's really important. What's one of the most common causes of loss of smell? It's head trauma, because when you hit your head in a car accident, you get shearing right here of the olfactory nerve fibers as they're passing through the cribriform plate. So we see loss of smell quite a bit after someone's had a head trauma. So again, olfactory bulb, tract, going back here to the uncus. All right, so what are some reasons for loss of smell or hyposmia? Anosmia is complete loss of smell. Head trauma. Later on, when we talk about brain tumors, we'll spend quite a bit of time on meningiomas. This is a benign tumor of the meningeal cells, and very frequently they will grow about in this area. And so a concerning presentation if someone has headaches, from a mass lesion growing there, and then loss of smell. We'd want to think about, certainly doing a brain scan in that setting to look for a meningioma right in that location. Very interestingly, Parkinson's disease, like more than 90% of patients with Parkinson's has loss of smell, and that will often predate the Parkinson's by many years. So there's some interesting ideas about why that may occur. We'll talk about in the Parkinson's lecture. And then I would say most of the common causes of loss of smell are not neurologic. So the patient has lots of sinus infections. That'll cause loss of smell. Or the patient smokes. Lots of other reasons for that. So most are not neurologic. And I always mention this, and it's not just because it's kind of funny, but just practically. But if you think that the patient you're seeing, that this is going to be a medical legal situation, we always check sense of smell, because this is something we don't do routinely. You will get used to in the third year. When you're reporting your exam, you will say cranial nerves 2 through 12 intact, because we don't usually check sense of smell. It's usually not that important unless the patient complains of it or we're worried about one of these conditions. But if it's a legal case, we'll always check smell. And the reason is it's a common legal tactic, and I've experienced this in court, was, well, doctor, did you do a complete neurologic examination? And you say, well, look at my exam. It's very impressive. Yes, I did. Did you check the number 1 cranial nerve? And, well, it's not important, it's not relevant. So you didn't check the first nerve, and so it's a way of making doctors look bad in court. So don't get trapped by that. All right, so here is a meningioma right here, kind of sitting at the base of the brain, and that will affect olfaction. Now, smelling salts release an ammonia gas, okay, and this is very irritating to the mucosal membranes, but this is not a way to check sense of smell. Okay, this actually activates the pain fibers in the trigeminal nerve. Okay, so this has nothing to do with assessing smell. It triggers an inhalational reflex. Okay, I'm just going to go over one thing here because it's a nucleus, one that I didn't show you in our first few lectures, but we should be able to see in the lab today. So we'll just say a little bit about vision. So the optic nerve is right here. Okay, the optic nerve comes back to the optic chiasm, which is right here. And so we can assess vision from the optic nerve all the way back to the occipital lobe in several ways. First, by checking visual acuity. Next time, I'll tell you how we assess visual fields. We have the ophthalmoscopic examination, and then the pupillary light reflex. So these are our 4 objective ways to assess the optic nerve and vision all the way back to the back of the brain. All right, so visual acuity, of course, we have our Snellen eye chart, and this really assesses central what we call macular vision. Okay, and so the macular fibers, actually half of the macula goes to one side of the brain, half of the macula stays on the same side. And interestingly, if you lose half of your macular vision, let's just say we were to have a huge lesion on one half of your brain, your visual acuity is still going to be normal. You need to lose more than half of your macular vision to affect visual acuity at all. So only lesions anterior to the chiasm, let me come back here. Here's the chiasm. Only lesions here of the optic nerve or something in the eyeball itself are going to affect visual acuity. If we have any large lesion, even back here in the occipital lobe, that's not going to affect visual acuity. Okay. Later on in the neuro-ophthalmology lecture, I'll come back to this, but here is the information coming back from the retina, going back to the brain, and I just wanted to highlight that the macular fibers cross right here in the center of the optic chiasm. So half your macula goes this way, half will stay on the same side. So again, a big lesion back here. Patient's going to do fine with visual acuity testing. They'll have visual loss, but not in terms of visual acuity. So something that would affect visual acuity would be a lesion right here of the optic nerve. And so a classic condition that does that is multiple sclerosis. I'll keep giving multiple sclerosis out as something, that common that will cause neurologic problems. But multiple sclerosis causes, remember, subcortical lesions, white matter lesions? Well, anything that is myelinated by oligodendrocytes can be affected by multiple sclerosis. And the optic nerve is really a central nervous system pathway. It's just like the subcortical white matter. It's myelinated by oligodendrocytes. And so a lesion here from multiple sclerosis, we call that optic neuritis. And because the lesion is anterior to the chiasm, very profound loss of visual acuity. The patient will describe something like this usually. They can't see in the center of their vision, and that's what you need, right, when you're looking at that Snellen eye chart or if you're going to try to read. So it's very profound visual acuity loss. Okay, so visual field testing. I'm going to start up on the next lecture with this because I just wanted to show you a little bit of anatomy and then a video. So we have the optic nerve, the optic chiasm, okay? And from the optic chiasm, we have the optic tract, which is a pathway that goes back to this nucleus. This is really what I wanted to show you here. So remember I said anything that has access to the brain has to go through the thalamus, except for smell. So vision has to go through the thalamus, and it goes through this thalamic nucleus right here, which I hope you'll all be able to see today. It has a shape of a Napoleon's hat. If that helps you, it's a very distinctive nucleus. This is called the lateral geniculate nucleus. Okay, this is the relay nucleus for vision. So it goes from the optic tract to the lateral geniculate, and then the optic radiations take that vision back to the occipital lobe. Okay, so that's just a little bit here on the anatomy of vision. And remember when we talked about the boundaries of the hypothalamus, I said look for the optic chiasm right about in this area. This is not a good example of it, but that's about where the optic chiasm is. And then of course we've got primary visual cortex all around the striate cortex here. Okay, so let me stop there, and I'm going to show you a video of a patient with a Wernicke's aphasia.